Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everyone. Welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon, and I am here with two folks, Samantha Murell and Whitney Lewis, and we are talking about platinum chemotherapy. Maybe we both just start by introducing ourselves. I'm a physician scientist who studies lung cancer. Whitney, what about yourself?
So I am a clinical pharmacist by training. So I went to pharmacy school and then I did 2 years of postgraduate residency in internal medicine and oncology pharmacy. And then I worked as a clinical pharmacist in Houston at MD Anderson for the last 11 years before I transitioned into pharmaceutical industry.
Nice. And Samantha, yourself?
Hey everyone, I'm Samantha Murell. I am a patient advocate. I have stage 4 lung cancer with a HER2 mutation. I'm happy to be here.
Awesome. Well, thanks for joining us. And today, we wanted to talk about platinum chemotherapy. It's one of the most commonly given types of medicines in cancer, and it's, in my opinion, still one of the most effective things that we give. And I think there's a lot of stigma around chemo. There's particularly a lot of stigma around these platinums. And I wanted to dive into it with the experts. Whitney, you're a clinical pharmacist. You've advised, hundreds, if not thousands of patients on platinum chemotherapies. And Samantha, you've received it. So these are, we have the academic expert and the experiential expert here. And, couldn't picture a better group to demystify what's going on with platinum chemotherapy and what it is. The first question I had is, to Whitney, what is platinum-based chemotherapy and how does it work against cancer?
Yeah, that's a great question. Like you kind of alluded to, platinum really is a true backbone for a lot of cancer treatments. We refer to it as platinum doublet quite a bit, or just platinum chemotherapy. And really, platinum drugs are just a specific class of chemotherapy agents. They've been around a long time. Cisplatin, for example, was kind of accidentally discovered back in the 1960s and has been used commonly in human patients since the 70s. So, 50, 60 years have we been utilizing it. I think everyone's kind of familiar with the shape of DNA, right? Kind of that laddered helix. And so the way that these drugs work is by getting into the nucleus of the cell, and that's where DNA is housed. And then the platinum agents bind to the proteins on DNA. They don't get into the DNA itself. They bind to kind of like a surface amino acid or protein. And that binding then starts to sync other bonds. So you get these chemical bonds that do interstrand DNA bonding and then intrastrand. So both, like DNA is made up of two strands. So you get like these extra bonds everywhere, and it just causes this weird kinky shape of the DNA, kind of like if your hair gets caught in the hair dryer and then you get to pull it out, it's like this really weird shape, right? So it just totally, it damages the DNA. It makes it this totally weird shape. And then platinums are kind of a cool concept. That DNA damage, it's not cell cycle specific, really meaning that like the cancer cell can die at any point. It's not, it doesn't have to be a certain point during the cell replication cycle for that chemotherapy to work and for the cell to die or undergo what we would call apoptosis, just meaning the cell has died. And that's really, I think that's like platinum agents aren't really used by themselves very often. Like we kind of alluded to, they're a backbone. They can be a doublet. So often there's two drugs together. And so having an agent that damages DNA that can work at any time really makes it easy to combine rationally with another agent to kind of get this like synergistic buildup of two totally different mechanisms to kind of target the cancer in multiple ways.
So something you mentioned that I think is really interesting is a lot of times we have this idea that you hit cancer with some sort of initial therapy, the cancer shrinks down everywhere, and then it's kind of sleeping. And people who are, particularly people who have metastatic cancer or stage 4, incurable, it's spread to different areas and we can't cut it out, they'll stay on therapies for a while. And there's always this question of like, if the cancer is not dividing, it's just hanging out there and it can hang out there for months or years, is the therapy doing anything? And you're saying that with platinum types of chemo, they can still be effective. It's still worth continuing it, even if we're not seeing cancer growth. Is that right?
I think that's right. Chemotherapies like this in general tend to work most effectively on cells that divide rapidly. And some of that is just because they're going to be a little bit more drawn, more likely to enter the cell for a cell that's been dividing rapidly. That being said, platinums can hang out in the nucleus with the DNA for a long time. So I wouldn't say that you wouldn't get any benefit if the cancer is sort of slowed down its trajectory. And really, with metastatic cancer, we're okay as long as the cancer's not growing. I would still say there is quite a bit of therapeutic benefit for a patient as long as their cancer's not growing through the chemotherapy.
Yeah, that makes sense to me. I think a lot of people have this question of the tumor shrinks, I don't see it, you don't see it, but you're still having me come in and take, therapy of some sorts. And, there are people who are on these platinums for a long time. And I imagine they have this question of, is it worth being on it if the cancer's just hanging out? So it's nice to hear that mechanistically, how we believe these therapies work, it does make sense to keep that pressure on.
Yeah.
Another thing that you mentioned that it was kind of accidentally stumbled upon. I'm forgetting the history of platinums. What happened?
I forget how they discovered it, but somehow in like a microbiology lab, a bacterial culture was kind of exposed to cisplatin and it had bacteriostatic, meaning bacteria weren't growing. They weren't necessarily dying, but there were that bacterial culture wasn't growing anymore, kind of similar to how they discovered penicillin, actually.
So, yeah, like all the major discoveries were like really,
Oopsies.
really bad scientists who like had terrible sterile technique. So for all of my future colleagues in the lab, we'll have to make sure we don't use fume hoods and just do everything on the bench, and then we'll find some big discoveries.
Exactly.
So, you mentioned that platinums come in, they bind to the structure of DNA and they change its structure. How does that change DNA's function? Usually it's in this helix, it'll unwind and it serves as a template to eventually make proteins. Is that template no longer functional? Like, what does it do?
Yeah, that's exactly right. So I think it depends a little bit on where in the helix it binds. If it's we've got lots of different chromosomes, right? So it may take a while until you need that specific gene that it's changed the structure of to actually kind of, oh, we need to unwind this and replicate, and then it can't. That being said, it's not cell cycle specific. So simply having that DNA damage can cause enough oxidative stress and mitochondrial dysfunction that it may induce the cell to die anyway, even without needing to try to replicate that DNA. But that's why it can work so well with other agents that specifically target DNA replication. So we have this change in the DNA, and then as soon as it comes to try to replicate it, it can't. So there's kind of a nice theory for why like certain combinations are even more beneficial. We get this like logarithmic benefit when we have more than one agent on board sometimes.
Yeah, and you mentioned something where it tries to replicate, it can't, and then it undergoes this process called apoptosis. And I think a lot of times when we're thinking about targeting cancer, it's like the idea is that you go in there and eradicate the cancer. You go in and you kill it. But this is an example where we go in there and we cause enough disturbance that the cancer undergoes its own program of death.
Very good.
So it's not necessarily like you did something that maybe inherently insolvable to that cell, but it's so damaged that the cell undergoes this normal process where it breaks itself down. And other therapies work this way too. But I think a lot of people have this idea in their head that we're bashing it with a chemical hammer, and we kind of are. But, the cell also has this program that we tap into, which, the cells in your body do this naturally. This is natural turnover, natural apoptosis. But if a cell's so messed up that it can't function normally, it'll dissolve itself, and that's kind of the process here. Uh, Samantha, what about all that was still kind of mysterious or needs clarifying, you think?
So the big thing for me, and I'm still curious now, and this might be just particularly to lung cancer, it might not, but I was on carboplatin, pemetrexed, and diverbolab, and after 4 rounds, I dropped carboplatin, which I think is pretty common. I think it's around 4 or 6 rounds. There wasn't any benefit after that they found. So I'm just curious, is that the case for everyone? Why the 6 rounds? Why is there a limit to how much platinum chemotherapy you can have, or is that just specific to lung cancer?
Whitney, I'll let you tackle this one.
Okay. So I think that's a great question, and you're absolutely right. It definitely depends on the type of cancer that you have.
Okay.
We have some older trials in lung cancer that essentially demonstrated exactly what you said. The benefit after about 4 or 6 rounds of platinum chemotherapy kind of plateaued, but continuing to give patients more chemotherapy was causing them more side effects. But again, without like that benefit in preventing the cancer from growing. So after about 4 to 6 rounds, you drop the chemotherapy, let the body recover, because we know more in this particular case isn't better, but that's also not the case for every single type of tumor.
Okay. Interesting.
Yeah, and you'd also see that the duration of time that one would recommend to be on a platinum changes. And this, I think there's a common idea in cancer medicine that more is better anti-tumor activity. Like, give me a higher dose, give me a longer duration. And I
That's
totally
me.
understand where, yeah, I totally understand where that thought comes from. And back in the day, that's like what researchers did. They did the maximum tolerated dose for as long as someone would tolerate. And it took a while for studies to come out and showing that actually it's just as effective if you don't do that. You can lower the dose, you can lower the duration. So it's not necessarily mechanistic where these recommendations come from, meaning like this wasn't derived in the lab that you get 4 cycles. This was, we tried it in people over years and years and years and additional fine tuning. And I think a lot of the material that's on there on social media, a lot of it is thought based. It's like, this works this way, so therefore this probably happens. Like, we now know platinums work by, gunking up the DNA so it can't really be used. So do that as much as you can for as long as you can, and that'll be better. And in theory, great. But you have to run out the experiments and see the experiments here being clinical trials. So I think it's really important to just follow that data forward and understand how these drugs are most optimally used in the human. And I think that's a good segue of, we've mentioning platinums because it's a class of drugs, as you mentioned, Whitney. What are the most common platinums that are used?
Yeah. So there's three major platinum compounds that are used in the U.S. There's some others globally, but in terms of what's used here, we have cisplatin, which was the first. About 10 years later, carboplatin came along. And then there's a third agent called oxaliplatin, which is really only used in colorectal cancers. But that is one of the big cancers, top four. So it's still very commonly used, but not as common outside of that specific type of tumor. So those are kind of the big three.
And was there a rationale for why one used in one context and Like lung cancer, we use carboplatin, sometimes cisplatin. We don't really use oxaliplatin, as you mentioned. Is
Yeah,
there
I think
reason
there's
behind that?
old data, and it was just a little bit less. My recollection is that it was just a little bit less effective in lung cancer.
Yeah, I think it's funny how much of what we do was based on just the study they did at the time. And it's like, could oxaliplatin be good in lung cancer? It's like it could possibly work, there's no intellectual reason it wouldn't. Um, but you don't want to take a chance on stuff that, didn't show as much effectiveness 30 years ago. Uh, and then, you get new insurance stuff and who's covering what. But, but a lot of it is just the study that was happening at the time. Um, I know we think cisplatin and carboplatin in lung cancer are pretty comparable. There are differences, but they're not like dramatically different drugs because they're both platinums. Um, but I know people are going to be listening to this who have one type of cancer and they're probably wondering why did they get, one type over a different type. And I think a lot of it is historical precedent. It's just like what's been done for a long, long time. And this stuff was evaluated years ago. And there's probably not a whole lot of benefit in risking evaluating it again. I don't know. That's my theory.
I think that's probably right. I think there are a few tumor types that are just more sensitive to cisplatin, and so that's why that will be their preferred agent. They've done all kinds of like retrospective analyses to look at that. So for the most part, they're very comparable, or, you could say like, well, maybe one is like very slightly better, but not to the point where it might even be worth the trade-off in side effects. So I think, for the most part, we kind of know that they're pretty equivalent. There are some clinical nuances there. So it just sort of depends a little bit. Or, for example, cisplatin's a better radiosensitizer. So that may be a preferred agent for some types of tumors if patients are also getting radiation at the same time.
That's interesting because what I found from other patients is a lot of stage 3 lung cancer people get cisplatin, but they often also get radiation. So maybe that's one of the reasons, but also cisplatin might be, like you said, a little creeping a little bit better, but there are harsher side effects, but you're going for a cure, right? And so stage 4, most people I've seen go on carboplatin. There have been a few people on cisplatin, and I'm like, why did you get that? I should have got that. But it's interesting about you saying about the radiation, because a lot of stage 3 people get radiation. So that probably makes more sense on why they're getting cisplatin.
Yeah. And there are, even in the metastatic setting, there are examples where one tumor type, as you mentioned, Whitney, is like the correct answer on what you should do has been evaluated. And even recently, and and there is a clear answer. So I should take back more what I said about them being kind of interchangeable just about historical precedent. I think some of that's true, but there is some data to drive one being better than the other, even though they are pretty similar. I'm thinking about this kind of relatively like platinums versus other classes of chemo. But even within the class of platinums, it's so interesting. I don't understand why certain tumors are more susceptible to one versus another, but there is evidence to show that.
So I have a quick question. If a person goes on one, like I've been on carboplatin, is there ever a world where someone, after they've tried multiple rounds of treatment, will then try another platinum chemo? Or is that not really a thing?
Whitney, I'll let you field the question.
That does happen sometimes. I would say in general, it's a little bit less common if it wasn't because of our side effect to switch. But that's not to say that, if somebody's on carboplatin and pemetrexed and did well, and then the disease is starting to grow a little bit, it's not an unreasonable thought. Like, they're still getting benefit. It's slightly different. We could switch out the backbone and do cisplatin plus something else and just see if we can get some of that incremental benefit.
Yeah.
Again, I think it's a little bit less common, and it's probably more common to switch from cisplatin to carboplatin. But for
Interesting.
example, like ovarian cancer, at least when I was training like 10 years ago, they did plenty of switching. So
Interesting.
I do think that that happens sometimes.
And I know it's all nuanced and I know it's all patient specific. I was just generally curious because I saw for me personally massive benefit from carboplatin. And as soon as carbo was dropped, things started to rumble. So I knew that carbo was kind of my win for that period of time. So just curious.
Well, and you mentioned that for lung cancer and many other cancers that use these platinums, we'll use them for a period of time, stop the platinum,
Hmm.
and usually kind of continue something else. So it's possible that the tumor is still sensitive. Like that doesn't necessarily mean because you've seen it before, it won't work again in the future.
Yeah.
And a lot of providers will re-challenge it at some point,
Yeah.
whether it's the same one or often it's going to be the same one if it was working. So to think that just because you've received something in the past means your tumor is definitely resistant to it, not always true.
Mm.
And I think platinums are a good example of that because they are heavy lifters in oncology. They're the backbone of a lot of things. They're pretty powerful drugs.
I'm a massive proponent of it, and I'll speak all day long about how incredible platinum chemotherapy is. And there's such a bad stigma associated with just chemotherapy in general. And it aggravates me a lot because it shrunk my tumors by, I don't know, 70%. I mean, it was insane. And it gave me more time. And I know you're going to ask me questions about this, Kyle, but like my rant is already beginning in that like it didn't do that much damage to me in the long run, and it gave me great benefits. So I think people are always going to weigh up the pros and cons, but at the end of the day, I don't think people should be as scared of these therapies as they are. There's a lot of fear mongering online, and it's really unfortunate.
Yeah, I mean, kind of just building on that, when you were first told that you were going to get chemo, and that was your first thing you got, right?
Mhm.
Like your first line was chemotherapy.
Yeah.
And that's scary. A lot of times when we're as providers, we like to have other things because we know the fear around chemo, and some people really do have side effects. So, with the understanding that your first line was chemotherapy, what was the perception that you had around carboplatin?
Well, first of all, not myself. My mom cried because she was like, I don't want you having traditional chemo. Like that was her perception. She's 65. She's associates chemotherapy just being this blanket awfulness that's going to destroy every cell in my body and make me weak. That was her assumption. For me, I was kind of like, bring it on, let's kill this cancer. But I was nervous about hair loss. I was nervous about neuropathy, digestive issues, tiredness. They gave me a pamphlet of all the side effects, and my goodness, there's a lot. But I did not. I deliberately didn't read it because I'm very much a person who creates their own symptoms if I think about it. So I didn't want to be swayed by the side effect leaflet. So it was kind of a surprise to me when I did have some symptoms, but there's just a really bad perception, and I didn't want to going into it have all of those perceptions.
Yeah, I think there's an image that was probably from the 60s through 80s era of people on chemotherapy and what that looks like. So I know the image that you're conjuring or what that sensation people think would be like. What was your experience with chemotherapy and how did it contrast your perceptions of what it would be like?
For me, I was told through multiple support groups that I'm part of that platinum chemotherapy was cumulative. Whitney, feel free to interject here if I say anything wrong, but very much cumulative. So my first round might not be that bad, and then the second might be a little worse, and then third, fourth, oh boy, you kind of wake was what I was told. And for me that was pretty accurate. My first round, I think the next day I was hiking 6 miles. I mean, I wasn't that bad at all. It always hit me on day 5 when the steroids wear off. So I'm not sure if this is the case for everyone, but I was given steroids with my treatments. And so once the steroids wore off, that was when the symptoms kind of showed. But round 1 and 2, I didn't really have that many issues apart from a little bit of tiredness. Round 3 and 4, I had pretty bad nausea, but nothing medication couldn't solve. But the fatigue was a very big thing for me. On round 3 and 4, I was really still trying to hike, but I was going at a very slow pace and felt like my muscles weighed 5 times what they actually weighed in terms of my ability to move. And I was told if you can push through that fatigue, because you'll become less fatigued. So that's kind of what I was trying to do. Trying to get to the mailbox as an example, instead of doing a 5-mile hike, just to get some blood flow going. And that certainly did help me, but boy, was it hard.
And Whitney, does that symptom profile, how does that compare to what you counsel patients on or what you hear?
I think that that's pretty representative. I would generally counsel patients, like, for the most part, if you're going to have nausea, you typically kind of know what that's going to look like the first round. And that kind of tells us as clinicians how we would need to maybe adjust or tweak some of your meds. But things like that fatigue that you described, I think that's absolutely, it does tend to creep up, and can be a little bit more, to your point, cumulative. There's not like a lifetime dose for platinums the way that there are with some other types of chemotherapy, but I think those symptoms can be a little bit cumulative and kind of, for some patients, can build cycle to cycle.
Interesting.
Yeah.
And Samantha, one of the things you mentioned is, you had steroids with it.
Mm-hmm.
And I think the things that we now give with platinum chemotherapy that we maybe didn't give years and years ago have changed the experience and how people are able to tolerate it. Whitney, what are some of the things we add to platinum now to make it more tolerable?
I think we have a lot better nausea medications. I think your mom's reaction is very valid. I'm sure she knew people, and that was absolutely their experience. I think we have gotten a lot better. We have a lot more types of nausea medications. We understand hydration and the importance of keeping people as active as they're feeling able to be, the balance of nutrition, and just kind of taking a more holistic approach. So hopefully, the people that feel like your mom was imagining are fewer and fewer. So, for example, steroids are a fantastic anti-nausea medication. Those work synergistically or kind of in an additive way with some other newer types of anti-nausea medications as well. So for somebody that gets cisplatin, I mean, I would want to make sure that you get, at least 3, if not 4 different types of nausea medication just to help control all of that. Both during, like, right before your treatment and for a few days after, as we know, the drug's still kind of working its way out of your system, and there can be some lingering nausea.
Yeah, and Kyle, I know we want to do a different podcast on this. He knows what I'm going to say. But I have a favorite drug for nausea that was an absolute game changer for me on my current treatment, but I'm sure it would help people who have extreme nausea for platinum, is Zyprexa. So Zyprexa literally was a game changer for me in terms of managing my nausea, and I could function as a normal human being, whereas before I absolutely could not. And the traditional nausea meds were not hitting it. And so Zyprexa was incredible. And it's allowed me to gain weight too, which I desperately needed. So it's had many benefits for me. And I kind of talk about it all day long to people who are really suffering with severe nausea, because being nauseous in bed is just no life to be had.
Yeah, Whitney, could you speak a little bit to what Zyprexa is and why there may be some stigma around it?
Yeah. So I'm first of all, Samantha, thank you so much for sharing that. Because Zyprexa is also my favorite rescue medication for
Yay.
nausea. And it's something that, a lot of patients can be a little bit understandably reticent to want to try. Zyprexa is FDA approved and marketed as an antipsychotic drug. It's very effective against schizophrenia, and may have some additional benefit in other psychiatric disorders. Of course, that's not why we're using it here, but a lot of those neurotransmitters in the brain can also, in a different balance, cause nausea. And so it's actually been studied several times in several different ways in cancer patients who are receiving very nauseating chemotherapies. And compared to anything else that we have, it is absolutely the most effective drug for what we call delayed chemotherapy induced nausea and vomiting, which just means after that 24-hour mark. So a lot of times, we'll give kind of a lower dose. It can cause a little bit of fatigue. I don't know what your experience with that was like. So we will sometimes do a little bit lower dose just to kind of ease patients into it. But I think you're absolutely right. They read the pamphlet, they're terrified or sometimes even embarrassed. The pharmacist filling it or the technician or, just they don't want anyone to think like, oh, I have this psychiatric illness. Of course, that's not why we're prescribing it, but it is very effective for nausea and vomiting. And I hope everyone, that listens to this would be open to trying it if they are having any nausea.
100%. Yeah. I'm someone who hates taking medicine. Before my diagnosis, I wouldn't even take an Advil. And so for me to take Zyprexa was a mental step for sure. But seeing the benefit, I was just like, wow. I mean, the difference was insane. And this isn't on platinum therapy. This was on a different one. But my first round, I was bedridden for like 7 days, and I was thinking that maybe I shouldn't even do this drug and contemplating coming off it. And then the next round I did Zyprexa, and I didn't have a single day that I was in bed. And it gives me the best sleep of my life. I call it a Zyprexa sleep. And I'm on the lowest dose. I'm not on a high dose by any means, but it gives me a beautiful sleep every single night. Do I wake up groggy? Absolutely. But, those are the trade-offs you do. And it's made me also gain 15 pounds, which for me was a massive benefit. It makes me hungry all the time. So I eat, and cancer patients need to eat and gain weight. So big proponent of it all around.
Yeah, it does have some appetite stimulants as well. So
Yes.
it can also help a little bit with anxiety for some patients. So I
Yes,
think
it does
there's
for
a
me.
lot of reasons, that it could be beneficial.
And when you were first prescribed Zyprexa or olanzapine is the other name people may be hearing for that, were you nervous about starting it? Did you have concerns?
Very nervous. I read all the side effects and was like, hell no. But I kind of bite the bullet. I got firsthand experiences from other people and what they'd experienced on it. And so I was like, I'll give it a try. And I haven't looked back. And now I'm on it all the time. I stay on it just because it has helped my anxiety so much as well. So I'm like, I'm just going to stay on it. I haven't seen any like really bad side effects from it. And I talk about it 24/7 on Instagram because there are so many people just having debilitating nausea on chemotherapy treatments. And it's miserable and heartbreaking to see that people are like that. And I'm like, there's this wonder drug. Have you heard of it? and a lot of people have not. And I'm kind of shocked because, Kyle and I have spoken that it's kind of standard of care. once all other avenues have been exhausted for nausea. So, but I'm happy that I can share my experience with other people, and they've asked their provider and they start taking it and they're like, this is a game changer. So it's great to see.
Yeah, at least, in my practice, when I've been chatting with people about things like olanzapine, Zyprexa, or, back in my internal medicine days when I was talking about anti-anxiety meds, a lot of people have this concern that it's going to change their personality, they're going to become a zombie, especially when you have this stigma or the nomenclature of it being an antipsychotic drug. Because I think people have a perception of what antipsychotic drugs do from the really heavily sedating ones that are used inpatient. They see it on movies and people become zombified. Did you notice, Samantha, on olanzapine, Zyprexa, any change in your personality? Anything like that?
Just that I was less anxious. My anxiety kind of forms in like a physical way, like muscle tightness, and like shaking and stuff like that. And that's completely all gone away. I mean, my anxiety's still there, Kyle, because I call you and I'm anxious as hell about certain things. But just in terms of like my physical state, is definitely completely vanished, which has been a massive benefit and offshoot of it.
But your thinking is still pretty normal. You're still you.
Oh yeah, definitely. Justin, my husband, would be the first one to tell me, and I'm still my annoying self.
Um, well, that's great. Getting back to the platinum, what did we'll say starting with Samantha, what did your care team do to prepare you to start this medicine? Anything that helped?
They told me all the different drugs they were going to give me to ensure that there were less side effects, whether that be the steroids or I had, I believe, an injectable nausea medicine that was given to me that lasted 3 to 4 days. And they just kind of prepared me in that way. Like I said, they gave me the side effect sheet that I didn't read, and and yeah, that was essentially it. But I was really excited to get going with it because I knew that it could potentially do some magical things for me. At the time, I was really sick. I was really underweight. I wasn't doing good, and I needed to be treated as soon as possible. And this was an effective way of doing that.
You raise a really good point here that a lot of people have this perception that chemotherapy is going to make them feel terrible. And if they already feel kind of bad from the cancer, they're worried that the feeling of being on the chemotherapy is going to make that worse. And I think there are circumstances where that can be true, but a lot of times the chemotherapy will make someone feel better. And I think this is hard for people to sometimes wrap their head around. It's when you're feeling so poorly because the cancer is growing and that makes you feel like crap. Like that your body is not accustomed to dealing with that. So when you feel poorly because the cancer is growing, the chemotherapy will make you feel better. And I think that's a hard thing for people to sometimes grip when they're first being read the side effect list. And they're like, can I really add this on top of how I'm feeling right now? Um, so it's nice to reassure folks that no, I think you're probably going to feel better pretty quickly. How
Yeah,
long
I
did
would
it?
say, yeah, I was going to say, yeah, after probably round two, I was getting my lung was filling up with fluid on a regular basis quite aggressively. And within round two, like things were starting to slow down with the fluid buildup. I was starting to feel better. I was starting to gain a couple pounds, like things were moving in the right direction. I was like, I genuinely don't feel like I'm dying anymore. It was that much of a change. And within the fourth round, I was like a new person. I mean, it was night and day, and it actually made me realize, oh, I really was really sick, and I didn't really contemplate how sick I was.
Yeah. Well, I'm happy some people get really nervous and they don't accept the chemotherapy. I've seen
Yep.
that. I'm happy you were able to push through that and you're a testament to how it really is one of our most powerful tools still. And I think we owe a lot to it. Um, Back to Whitney about side effects. We've talked about some of the side effects that Samantha's experienced. some of the stigmas around platinums, what are the most common side effects that people experience with these platinum chemotherapies?
So the side effect profile varies a little bit, kind of platinum to platinum agent, but in general, I think one of the big ones is just affecting our body's immune system. So a lot of people think that as the chemotherapy is being infused into them, it's already affecting their body's like mature immune cells. To a much greater extent, we're actually affecting like the little baby stem cells in our bone marrow. So as our adult immune cells die off over the next 10 to say 14 days, which is their natural life cycle, there's fewer little babies to replace them. So it's actually about a week or two after your treatment that your immune system is going to be generally at its lowest point for patients with solid tumors. So we see our platelets affected. You know, if you get a cut, that's what forms a scab. Our red blood cells are that hemoglobin, which kind of floats around, brings our body tissues oxygen. Kind of, if it's low, we often don't have as much energy. And then just those white blood cells, which help us fight off bacterial, fungal, viral infections. So that's a major side effect. We also see damage to our kidneys sometimes. So it's important to stay really hydrated. I usually tell patients 2 to 3 liters of fluids a day, unless you've been told by a doctor that you need to restrict that. There are a few reasons that might be the case, but if no one's ever told you that, then by all means, please hydrate. Nausea, which we've kind of talked about, there's kind of two different types of nausea. We call it acute and delayed. So acute's kind of that first 24-hour period where those IV drugs that we give you are really going to shine. And then, you have the steroids for a few days after. Some patients take Zyprexa for a few days after, or some other different medications as well to kind of help with that delayed nausea, which for most patients lasts about 72 hours. That doesn't mean it can't happen outside that window. That's just when it's a little bit more common. Weirdly, platinums can also cause damage to our hearing. So it's really one of the only drug classes. There's some antibiotics, but chemo-wise is probably the only one, at least that comes to my mind, that can actually cause damage to the nerves that help us hear. Our cochlea aren't able to help flush out some of the toxins from the platinum. We can also see allergic reactions. When we think allergic reactions, we normally think with the first or second dose. With platinums, it's actually the opposite. The more exposures we have, the more likely we are to have an allergic reaction. That really starts to peak after about like 5 to 8 doses. So that's still pretty rare, but it does happen. Hair loss is not a very common symptom with platinum agents. Sometimes the drugs we combine them with, though, can cause some hair loss. And then we can see some neuropathy or like damage to our nerves, or causing pain or loss of sensation there. So I'd say those are kind of the more common side effects of platinums.
And of those side effects, which are the ones that are least likely to get better over time?
Yeah, I think every patient's a little bit different, but kidney function usually goes back to normal or close to. It may take months. It depends a little bit on how quickly that kidney damage happens, why it happened, but that usually is something that resolves. The damage to our hearing typically does not. I think as humans, we're very resilient. We're often able to live through that, and a lot of people sort of tune out that tinnitus that can happen, or that ringing in the ears. That's sort of an indicator that there's been some damage to those nerves. It's usually high-pitched hearing frequency that's affected, not conversational frequency. So other than like that tinnitus, which can be, I don't want to overstate it, I'm sure it's very annoying, but that is something that's typically permanent. And then certain types of neuropathy, or that numbness or tingling sensation, for most patients, it does get better, but there is a subset of patients that will never have that resolved completely, unfortunately.
Yeah, and I think that echoes. There are a lot of folks who want to push through therapy, and I think there's this concern that if they bring up symptoms, then their care team will pull the therapy and their tumor is going to grow. So I think there's some fear around bringing up symptoms. And I want to, I guess, highlight or emphasize that some of this stuff goes away. And if you pushed through when we otherwise might pause, sometimes no harm done, you're just going to feel bad. But there are other circumstances where this stuff really gets worse and it might not go away. So it's really important to have that conversation with your care team, particularly if you're feeling the tinnitus or the ringing of the ears, hearing changes, your neuropathy, the numbness, tingling. Those are things that we really treat really seriously. And that's why we monitor laboratory testing so frequently. People get, Samantha, I don't know how many, blood draws you've had over your cancer course, but quite a few at this point, huh? We monitor that really, really closely. But there's stuff we can't monitor. We can't monitor if you're hearing ringing in the ears. I can't monitor if you have numbness or tingling. You have to tell me. So it's really important to trust the care team. And if they do a dose reduction or if they pause for a while, it's okay. We have data that shows you can do those changes, you can adapt. And a lot of times it's just as effective as if you if you stayed the original course. So those are important things to keep in mind.
I think that's a big one because, I see a few of my friends where they've had platinum therapy and like you mentioned, Whitney, like the white blood cells will go down and maybe they're so low now that they can't have their next round. And that makes them freak out that, treatment's delayed. What does that mean? My cancer's going to grow. And so the reassurance of like, if you wait another week for your white blood cells to rebound, like it's okay. It's not going to be the end of the world. And it's better to wait for that rebound to happen, whether that be through treatment or naturally.
And Whitney, could you speak to, at least in your clinical practice, you were in lung predominantly, how commonly do you see either treatment delays, treatment whole pauses with these platinums? How often does that occur?
I think it depends a little bit on a lot of things. We would see patients that, for example, maybe had breast cancer in the past, or, the average age of a lung cancer patient is in their 70s, right? So after like 45, I think you lose a little bit of that bone marrow every year anyway. It's fractional, but that still compounds over decades. So I think a little bit just depends on the patient themselves. There's also some genetic reasons why some people may just have a little bit less robust, at least in terms of the numbers that we see. It doesn't mean that they're less functional, but their numbers may be a little bit lower at baseline too. It's not uncommon though. I would, after 3-4 rounds, I would say at least maybe like 1 in 5 to 6 patients need a little bit of a delay or a dose reduction. And to Kyle's point, that in no way means that it's going to be less effective. It may just be that we didn't pick the perfect dose for you at the beginning.
And Whitney, could you explain, one of the big concerns we have is this neuropathy because it can last for a really long time. It doesn't always get all the way better. So we're really tuned into neuropathy. What is the process by which the platinums cause neuropathy?
So it's kind of interesting. So we talked about how platinum binds to like the amino acid building blocks of DNA on the outside and causes these additional bonds and a strange shape, right? So those are called adducts. And that weird shape of the DNA can cause some oxidative stress. And the powerhouse of the cells, the mitochondria, they can start functioning less optimally. And all of that essentially can cause internal damage to the cells of the neurons, if not like death itself. So it's sort of the same way that it works against the cancer as a bit of kind of collateral damage. And all of the platinums can cause that type of neuropathy. Oxaliplatin, which again isn't really used for lung cancer, but that has its own special reversible type of cold sensitivity as well. And that's because it affects these sodium channels, and it can cause this intense sensitivity to cold. So we'll tell patients wear gloves if you're grabbing something from the refrigerator. Don't drink any cold liquids. There's like functionally nothing wrong, but you may feel like you can't swallow. It may be very painful. But that kind of glove and stocking classic tingling or numb sensation is truly, it is nerve damage. And so depending on if it's causing like the cell to kind of die versus just that stress and lack of function, kind of, there's no way for us to know. It's really just tincture of time. But that's sort of if it's going to get better or not.
Yeah. And some of the things that I ask for patients to tell, are they having neuropathy? How bad is it? Do we need to stop? Do we need to suggest, is some functional questions like, if their ability to perceive pressure is, messed up from the platinum, they may reach for something and it slipped through their fingers because their sensation of how much pressure you're applying to something may not be accurate. Your ability to, one question, we ask a lot is, can you button up your shirts on your own? Do you have the fine motor, you need just quite a bit of fine-tuned nerve sensation to do something like that, even though we do it without thinking about it. But those things can really become compromised. People can drop mugs. And once that happens, we really have to think critically, are we in reversible territory? Are we getting to irreversible territory? These are the kinds of things that if you're experiencing them, you got to tell your care team. Whitney, any other red flags?
I think those are the big things. I mean, most of the time, platinums cause issues with our peripheral nervous system, meaning like our fingers, our toes. Very, very rarely, there's some reports of patients that have more central nervous system issues. So if you're having like a foot drop, something like that, or gait changes, then that's something that we'd want to know about. Just to rule out and make sure there's nothing more serious going on. But that's kind of a more serious conversation to have with the care team about maybe stopping the platinum altogether.
Yeah, and thanks for bringing up the long nerve thing. We haven't mentioned that, but your nerves usually start in your spine and then they extend out. So it's not like the nerve that goes to your hand is attached to a nerve, a couple inches later, and then another. That's one long nerve. And just like a power cord, it loses its ability to transmit information over distance. So that's why the long nerves are affected, is because that their ability to do their job is affected because they're more vulnerable. They're longer. The signal can be dampened. I'm sure a neurologist will correct me in this in my articulation of the problem, but that's my how I phrase it and how I think people remember it pretty well is the long nerves are going to be predominantly affected. But if you're having, and those are long peripheral nerves, those aren't originating in the brain directly. They originate in the peripheral nervous system. So yeah, if you're having other problems, you can't necessarily just chalk it up to say, I'm on platinums, I should be having some neurologic changes, neuropathy. You got to tell your care team about everything. This stuff's really complicated.
I have an out there item that isn't life or death, but I think worth mentioning. So I had changes in taste buds, like pretty dramatically. My aversion to red meat was very, very high. And then I also couldn't use metal cutlery. So I changed to plastic, which meant I didn't have a metallic taste in my mouth anymore. I've heard that was a common one, and someone passed the knowledge on to me that I needed to use plastic forks and spoons. So, not life altering, but little items like that, I think, are worth knowing so that people can make those little changes. But the the change in my, I loved eating a steak, but you put a steak in front of me after having carboplatin, I would run out the house. So just be prepared for potentially having changes in your taste buds.
Yeah, and it's interesting. Some of these things, I'm guilty of not counseling as much as the things that I'm worried are going to be irreversible or like the really scary things. So I think, Samantha, what you're mentioning is so helpful, and this stuff is complicated. It does take a village. Um, and the patient advocacy groups and where you can find people who are experiencing what you're going to go through, they're going to tell you things your care team just can't hit. There's just too many things. I didn't know about the cutlery thing. I've never advised someone to switch from metal to plastic. So you teach me things too.
Awesome.
Um, well, I mean, that's the whole thing. There's experiential, evidence. Like you went
Hmm.
through it, what it's like, and no one is designing a clinical trial to tell if they have a better outcome on plastic or metal cutlery. Like that trial's not going to happen. So, unfortunately, we're stuck with anecdotes. But anecdotes, they're real. So, so that stuff doesn't really make it into the trial data. Like you're
Right,
not going to see
right.
that. You might see change in taste, but it's not going to be specific enough that I have an aversion to red meat. Like
Yeah.
we're not going
Yeah.
to
I mean, that
know
might be
that.
just a Samantha thing. I mean, who knows? But
It could be, but if everyone had it, we still wouldn't know. Like
that's
it
fair.
still
That's
wouldn't come
fair.
up.
And I want to say the biggest thing that, I love my care team. And like you said, they can't cover everything. The big thing that I found kind of shocking to know about for someone that's just starting on platinum chemotherapy is not to share, and Whitney, I'd love for you to talk about this a little bit, is to not share a bathroom with family members for X period of time while it's in your system. I think I found out, and again, tell me if I'm wrong on this, that it's carboplatin stays in your system for around 3 days. And so I wasn't allowed to share a bathroom for that 3 day period just in case. And then I don't have children, but you're supposed to be careful around sharing mucus or whatever with your children. In case of transfer, and then pets. And I don't know if you can talk about that a little bit. That might be me going to the extreme of what I found out from other people, but I'd be curious to know your thoughts.
I think there's a lot of like what we think might be best practice
Hmm.
as well. Um, Generally, we would say a drug is sort of out of your system by the time it's had 5 half-lives, which would just mean, like, let's say I gave you 100 milligrams of drug, one half-life would be half of that, so it would be 50 milligrams in you. Then half that again would be 25, etc. Um, I would expect carboplatin and the metabolites or how it gets broken down, those chemicals as well, to be out of your system in a couple of days. I I do think that there's a lot on the internet that kind of talks about flush your toilet twice if you're sharing with
Yeah.
family,
Yeah.
and things like that. And I think that's probably a best practice.
Yeah.
But I wouldn't feel strongly like I've never told someone that they couldn't share a bathroom with their family members.
Oh, interesting.
Um,
Okay, good to know.
yeah. I don't, unless you have a low flush toilet, even, I don't particularly cancel like you should flush twice. Because the amount that's coming out of your body after the first few hours is already
Mhm.
so much less. So yes,
Interesting.
if you have like very small children, like again, abundance of caution, that's probably best. But your chemo's not coming out of your pores. Um,
See, and
Carboplatin's
I thought that
really,
was the case, so I'm good to know.
it's not, there are some chemotherapies that can, carboplatin,
Okay.
cisplatin are not
Yeah.
some of them.
Okay.
If you want to share a kiss with your loved one, please do so. The amount of mucus exchanged would have to be astonishing for, I think, anyone to be concerned about any sort of additional unexpected exposure. So I think, really, we want you to go live your life. I mean, be thoughtful about it, right? Like,
Mhm.
wash your hands.
Mhm.
God forbid you vomit. Of course, we're going to give you all of the medications to try to prevent that. We want you to be the one to kind of clean that up just in case there would be any sort of residue, or if you um, are a male patient and you're urinating and we don't 100% get in the toilet, then of course it would be ideal no matter what if you were the one to clean that up. But I think especially if you've had chemotherapy, that might be best for the family. But I think interacting with your pets, by all means, wash your hands. Your dog's not going to wash its paws, right? I probably wouldn't let my dog lick my face right after,
Yep.
during any of the course of the chemotherapy, just because, bacteria. But
Mhm.
interact with your kids, interact with your dog. If your kids are sick and you've had chemo, you are going to be a little bit higher risk for infection. So, like, if you can, I understand that's not always the case. Try to, maybe love from afar until you think they're not contagious. But, you're safe to be around. So we don't want you to feel like you have to be in like a little bubble. I think I can only imagine like how isolating it must already feel. And then to have some of that physical separation on top of it, it's really going to be your comfort level, but there's not like this really strong evidence that you have to do all of these things.
Yay. Well, I'm glad that I brought this up then, because there is very much a misconception online about how toxic you are. And I even educated my close family members of like, I'm super toxic, like you need to stay away from me for X amount of time. And this new drug I'm on, I think it stays in your system for around 7 days. So I've educated them to like I don't even kiss my husband for 7 days after my treatment because I don't want him to like get some fall off from my treatment. So I appreciate you kind of educating us on that, because it's a big misconception and I'm missing out now. I was missing out. Now I'm going
Both
to
of you,
change.
yes.
Yeah.
Yeah, and I think, I was thinking about this too because there's a lot of things where we have what's your tolerable level of risk, and for children, neonates, the level of risk that society will tolerate is virtually zero. Things that that any harm is permanent and terrible, we tolerate no risk. So people will dramatically adapt their lifestyles. And with the chemo stuff, if a small amount, like theoretically, a small amount of cisplatin transfers through a mucous membrane, that dose is not going to be high enough probably for it to register at all. The one thing that might, cross my mind is an allergic reaction, which are pretty rare. Like a small dose might be enough to trigger an allergy, but it's not going to be enough to trigger the other side effects we've talked about. And even that, that would be kind of suspect. Um, Whitney, I don't know of any evidence on secondhand toxicity.
I have never heard of a case report. Now, with certain bodily fluids, like for example, if you're a male that's had platinum, it would be recommended to use like a barrier form of contraception because there's like a theoretical amount that could come out in the semen, and you wouldn't want to expose your female or male partner to that. So I think that is sort of a separate consideration, but I've never heard of any sort of secondhand exposure triggering an allergic reaction, or otherwise from that perspective. Of course, again, not something that they would study, but I think the amount that comes out is so nominal. Most of these drugs, most of the platinums will be metabolized and come out through your urine, which is probably why there's so much about flushing twice and separate bathrooms. But again, as long as you have a regular flushing toilet, that's probably fine.
And now we can counsel men that while you're on chemo, don't pee all over the floor.
Ideally always, but yes.
Yeah, but at least while you're on chemo, you should be the one to clean up your own urine. Um, during those other times, whatever works. But okay, moving on here a little bit, Samantha, you were on carboplatin, you were on one of the platinums. You explained the symptoms, side effects you were experiencing. What were some of the things that helped you get through your treatment days?
What helped me get through was I kept telling myself that this is temporary. Very much like after my first round, I kind of knew what to expect on what day. So I very much had that planned out in my head of what to expect. And while I did have my breakdowns of just feeling like crap and just not liking it, I kept telling myself this is only temporary. I'm going to get through it. And in a few days, I'm going to feel like myself again. And that was always the case. And to this day, on my other treatment is the same as well. I have a couple bad days and I'm like, okay, this is my day 2 out of 3 that are bad. And then I'm going to be great on day 4 or whatever. So just kind of reminding yourself that this is not long term. Even though I'm on treatment for life, right? Like I still have my good days when I'm not on treatment and having those side effects. So just looking forward to those days, I think is critical.
Sure. And Whitney, what are the things that folks can do? This is either lifestyle, other medications, things that are like over the counter, um, different habits, foods that they could do specifically to offset the toxicities of platinums.
I think we get this question a lot. I would say in general, we should all live an active, healthy lifestyle. So, again, drinking plenty of fluids, staying hydrated is going to be really important to help with nausea. It helps with our energy levels, as well as just kind of flushing everything back out of our systems. Taking in plenty of nutrition. If something's raw, make sure it's been washed well on chemotherapy. Some types of chemo that affect our body's immune system a little bit more, that might not be the best time to have a raw oyster or sushi, especially if we're in a landlocked state. I think there are, in general, I would say, we should all have a normal, balanced, healthy diet, but there's really nothing you can eat that's going to make your cancer grow. So if you are craving a milkshake and some French fries, like please, maybe not every day, right? But if you're having a craving, I think it's really important to like satisfy that. But otherwise, stay active. That's going to also help with your body's kind of energy level and tolerance for activity. But we also really want to listen to our bodies. And if it's saying like, you need to take a break, don't hike 6 miles today, then that's like a good time to be like, I think I've had enough for today and I'm going to go rest for a little bit. Because I think there is kind of a concept of like energy conservation too. If you exhaust yourself, how much longer does it take to kind of regain some of that energy? And I'd love to hear Samantha's perspective from that too, on someone who did kind of really, really push through that. But over the counter drugs, I would say just make sure your care team's aware of everything that you're taking. A lot of supplements or herbal products. I think they have a lot of perception of being very safe because they are natural. Platinum is also a naturally occurring substance, right? But in the right dose, it's not always going to be the best. And 50% of known drugs get broken down in our liver. So as we have several of these drugs on board, we can see these drug interactions. So, I think just the biggest thing is kind of transparency. Like I'm always happy to review a patient's supplement if that's something that they're interested in taking, and just kind of having that transparent conversation of like, well, I think these ingredients are fine. I'm a little bit worried about these two, and this is why. And kind of letting, all we can do is recommend, right? I'm not going to go home and take the supplement from you and steal it out of your medicine cabinet. But, I think it's at the end of the day, it's up to the patient. And I hope that we build these trusting relationships in clinic so that our patients feel comfortable and safe coming to us with questions about side effects, and questions about things like supplements. Generally, I would say I don't really recommend anything more than a multivitamin, but I'm always happy to look.
And I think we could do an entire podcast on supplements and platinum chemotherapy. But you hit the nail on the head, Whitney, when it comes to that is, I my care team asked me what I was taking, and I'm sure I annoyed the pharmacist to all ends because I had the longest list ever, but I was transparent and I shared my entire list. And I think a lot of people are nervous about sharing that list. But at the end of the day, I shared the list and they only removed a couple, honestly. And I was pretty shocked. I was waiting for them to remove like 95%. And, but that just showed me that that pharmacist was like truly looking into it and respecting, one could say, my craziness of taking all these supplements. But, I felt therefore good in myself that, okay, there is nothing that I'm taking that's interacting in a negative way. But I think a lot of people are so nervous, and so they end up taking all of these supplements that potentially could have really bad reactions, and potentially make the chemo not do its job, which is kind of terrifying. And so that level of trust just needs to be there. And like I said before, if you don't feel like that with your care team, you should look elsewhere and find a new care team if you can.
Yeah, I agree. I think, we always want to empower our patients to feel like they get to own their disease as much as you can control it. But
Yeah,
we also want to make sure you feel empowered to do it in a safe way. It would be such a shame to go through all of that. And then, we're taking supplements that could make our treatments less effective.
right.
We are so carefully measuring the exact dose that you need down to the milligrams, but we can't account for some of these drug interactions. So, we could be underdosing you, or, overdosing is also bad. More of a good thing's not always the best. So yeah, I think it's just having that trust between patients and providers.
Yep.
Building on that, Whitney, what's the longest supplement list you've had to go through?
I had a PhD patient once, and actually I loved
Oh
her. She
boy.
was fascinating. We totally bonded over scuba diving, and like, such an interesting person. She had over 150 supplements, and I spent literal hours. And she was on cisplatin and getting radiation, so it wasn't even just the chemo. It's like, okay, well, what's got antioxidant properties, because that's going to make radiation less effective. So there was just like kind of a lot to go into it. And I was trying to type out notes and put in, I know she'd want the references, right? As she then critically evaluates my recommendations. But I didn't mind doing it. It was a very interesting task. But yeah, I've had over 100 easy. So don't feel bad about your list.
Yeah, I know there's so many people who are going to be listening and they have like 8 things and they're, oh, am I being too much? It's like you should see the lists we see. They're impressive lists, and there's no judgment there. We go through it, we do our job, we're there to serve you.
Exactly.
But it's unlikely you're gonna freak out your care team with how long your supplement list is. Are there any supplements or other things that people take, Whitney, that are absolutely a no-go with cisplatin, or any of the platinums, or is it contextual?
I think it's mostly contextual. There's actually some B vitamins that kind of interact theoretically with platinum. So I usually just have patients hold even like a multivitamin. Our foods are so fortified that it's pretty hard for most patients. That's not to say that you couldn't have had poor appetite for a long time. But a true nutritional deficiency that we can detect in a lab test is pretty rare with the way our foods are fortified now. Actually, platinums are usually a little bit easier because they go through the kidney mostly. Other drugs, that go through the liver, like the taxanes, which I assume you'll do a different episode on that. Those go through the liver, so that's like a whole other a big kind of concern and consideration for that. Again, platinums aren't often used by themselves. So it's kind of like not just looking at that in and of itself, but also kind of looking at what else we're using with the platinums. But, things like ibuprofen, for example, could theoretically irritate the kidney. And so can platinum. So, I usually request that patients at least try to start with Tylenol if they're having like the occasional headache or ache and pain. As long as they're not having a fever, because of course that, we don't want to mask any symptoms of a fever. But, if you've got a headache, I don't want you to just suffer through it. But, to try to protect your kidneys, at least try to start with Tylenol. Case by case basis, of course, but even just some of those benign things, it's not that there's a direct drug interaction, but overlapping side effects or, kind of hitting the same organ from different sides can also kind of cause some of these unintended side effects. So, we also don't want you to come into clinic and, your kidneys are upset and we have to hold your therapy for a totally different, reason. So.
Sure. Samantha, what advice would you give to someone who's just about to start a platinum?
I would say read the side effect manual if you want to. Prepare yourself if you want to. Join support groups to get firsthand kind of experiences from other people. But I will say every single person is different and how they have their side effects. So you could get 50 testimonials and you might have a completely different experience. So just bear that in mind. And then read into the other medicines they're going to be giving you just to prep you, whether that be steroids, nausea meds, etc. Just get an understanding of what you're going to be taking. And then drink a ton of water, as Whitney said. I have seen a dramatic difference when I don't drink enough in my side effects. And it's not only just nausea, but fatigue too. Makes a massive difference if I stay hydrated. So staying hydrated as much as possible. Sometimes I know it's hard because you don't want to feel like drinking because it makes you feel nauseous, but as much hydration as you can is key. Even like the days leading to your first round, just be as hydrated as possible. It can really make a difference.
Sure. Whitney, what about you?
I think it's important, just like Samantha said, like try to take it one day at a time. Recognize that how you feel today may not be how you feel next week. Take the nausea medications, all the supportive care medications that were prescribed to you. Please let your team know if they're not working. There's other drugs that they can try, but we're not mind readers. I'm sure we're working on it, but that's not something that we've figured out how to do. So if something isn't right, isn't working for you, please let your team know. They are there to help support you. We want to help support you, but we won't know what you need unless you tell us. Don't feel like, whatever you're experiencing is even necessarily normal. We don't want you to be shy. Be squeaky, send us a MyChart message like, hey, I'm getting a little bit of a rash or, XYZ, whatever it is. We would much rather hear from you, especially early on when it's, most likely going to be the most easy to intervene on. Then, a week later when it's like, oh, actually, this has now kind of spiraled or snowballed into something that's perhaps a much bigger deal to try to treat. Even things like patients will get cold sore outbreaks or, just things like that because they're immunosuppressed. Like just anything new or unusual going on with you, it may have nothing to do with the cancer, nothing to do with the chemo, but we'd still rather reach out and reassure you like, hey, that's, that happens sometimes. It's nothing to be worried about. Or, hey, that's a little odd. Why don't you come in for, this additional, this extra test just so we can roll out anything else. So, I think just be aware and be communicative. That's really like, that's what we want.
Great. Well, Thank you both so much for joining today. Hopefully this was informative for everyone listening as it was for me. I work in the field and I still learn a lot from, you, Samantha, Whitney. This was helpful for me. Um, any last sentiments before we cut you loose and let people carry on? All right. I think we covered it. Thank you both again so much for taking the time today. And that'll be it for this episode. We will see you later, everyone.
Thank you.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.